All right. Hi, guys. I hope everybody is doing well. And a few things that I want to say before we start this little series of lectures is that I've kind of changed the initial course. So in your text on chapter 35 is where we're going to be focused, but there's some additional information that I've pulled from other sources. And so your text focuses specifically on degenerative diseases of the central nervous system. However, for testing purposes, specifically for your boards, and then also just some other things that I wasn't as aware of whenever I started practicing, but they were that I saw kind of frequently, that I wanted you guys to be aware of too. So I've kind of pulled those in and stuck them in here. So some of them, most are central nervous system, but I'll be sure to point out if we do dive into the peripheral nervous system as well. Okay. Another little note is just to have in the back of your mind your treatment approaches. So I don't want you guys to be so focused on the trees that you lose sight of the whole forest. That was one of my big problems, I think, whenever I was in school, is that I would get so microscopic zoomed in on one little thing that I would forget to take a big aerial picture and just kind of remember where you are and what you're talking about, okay? So when we're going through this, I want you guys to think about what kind of approaches, what kind of treatment approaches that you would use for each condition. So specifically, think about using compensatory approaches with these progressive disorders, because this patient is not likely, they're not going to recover, okay? So we're not going to be trying to rehab and restore traditionally. So for things like ALS or muscular dystrophy, on and on, we're going to be thinking about how can we help them best compensate to have the best quality of life for the duration of the time that they do have left, okay? And then also think about the remediation and the rehab, the more traditional approaches that we like to use, and what those are best for. So those are best for the non-progressive disorders, specifically like maybe a TBI or a spinal cord injury, and some of the other ones that we'll talk about as well. But remember, as we're going through this, a lot of these don't have specific cookie cutter OT interventions that they're going to say, for this diagnosis, you do this. That they don't work that way, and not much in OT does, and that's why we like to say it depends so much. But it really is going to depend on how that client progresses and what level they're starting at, and then where they're trying to progress to, and what are their goals and what inspires them. Okay, so jumping in. The first slide that I've got for you here is kind of an overview and then a review of your anatomy. And this is a very broad view of your anatomy. So please jump back into your anatomy textbook if you need to review a little bit more. I would recommend that. But this is kind of just a little reminder of kind of your brain and your spine and those nerves that are shooting off. And then what happens is that nerve starts to degenerate, right? So that myelin sheath there in the top picture is normal. It's able to conduct and transmit as it should be able to. But then what happens as that myelin sheath or whatever part of the nerve is injured and starts to break down, right? We can see there that that's not going to be able to transmit as it should, okay? So again, that's just a quick review. Jump back in if you need more for that. I think jump back in is going to be the word of the day, the phrase of the day. All right, so starting out with ALS. ALS is amyotrophic lateral sclerosis. Okay, it's also known as Lou Gehrig's disease. It kind of jumped to fame a couple years back whenever people started doing the ice bucket challenge, and they're trying to raise money for this condition. And the reason for that is because not a lot is known. There is no specific treatment right now, and so we're trying to get more information and more research on that to figure out some sort of effective treatment. Okay, so ALS is also known as Lou Gehrig's disease. It's a progressive degenerative disease. Okay, so that means that it's a downhill trend. Okay, it's pretty sad in that way because it is a fast downhill trend. But it's kind of a umbrella term as well. So there's motor neurological diseases, and that kind of refers to a term, and ALS fits within that. So not something you need to seriously focus on, but just be aware that there are more, but ALS is one of the more commonly focused on. So the incidence there is 4 for 100,000, so it's rare. 90 to 95%, so almost all of these cases are sporadic, meaning that there is no genetic link. Okay, so most of the time we have no idea how these people are contracting this condition. We don't know if it's just sporadic, it's random. All right, and then you'll see up in the top corner there, I've got that it's rapidly progressing. So most die within 2 to 5 years from respiratory failure, if they choose to not undergo a trach or a vent to help them continue to breathe. 10% will live 20 years or longer. So that's kind of what you're looking at as far as the landscape of this condition. So pretty quick from onset to the end of the condition, right? Unless they choose to go to have the respirator or ventilator to help them breathe. And as we're moving on, we'll talk about that as well. It is part of OT's role as well as the whole rehab team, anyone that's working with this client, but it's primarily the medical director and the family's responsibility to decide what that client's end stage is going to look like. Do they want to proceed with a ventilator, trach, feeding tube? How long do they want to prolong the end of life? And so we've talked about these things before as far as having a living will or having their end of life wishes, and it's hard to talk about. And I've shared some stories before with clients that I've worked with, and that being one of the biggest obstacles is the family coping with this being a terminal diagnosis. Okay, so moving on into what ALS kind of presents as. We said the etiology is unknown. The clinical picture, though, it's kind of strange. It's not going to follow a certain pattern per se, but the clinical picture is going to look like focal weakness. So like not a generalized weakness, but maybe a point weakness in the arm, leg, bulbar muscles. And so remember about the bulbar muscles, that is going to affect, those are your lower cranial nerves. So 7 through 12. And that's kind of going to affect the face, the breathing. So we'll look into that more, but think about that. So maybe some trouble with the tongue, with the face. Swallowing is eventually going to be affected. And in the beginning stages, it may just look like weakness. They may start to drop things. They may be tripping a little bit more frequently. They may become short of breath. They may just have fatigue. Emotional ability is where they, for just no reason out of the blue, may start crying or laughing very inappropriately. Fasciculations is where, and you guys have probably even seen this on yourself at some point, but where your muscle starts to kind of just twitch in a place and you're not contracting that at all, but it just starts to kind of, you'll see it kind of, it's non-voluntary, but it's just moving around a little bit and starting to contract. So they may notice that. And then something else to realize here is that 50% of these folks do have cognitive changes. Okay, but it's important not to assume that everyone with this diagnosis is going to have cognitive changes. The client that I worked with most closely did not. She had been a teacher and was very alert and just very aware and very present. And she had actually come to terms, I feel like, a little bit more so than her family, and had kind of gotten farther into the acceptance process there. But again, as if everyone is not on the same page there, it doesn't so much matter. Okay, so as you guys, I'm sure, have been around the process of death and dying and how ugly it can be for family members, and sometimes, it happens faster and in a lot of different ways, but this is one where folks kind of see it coming more, and so it almost it presents different challenges that way. Okay, so thinking about that for the clinical picture, moving on then to the end stages of what it would look like. So feeding will become difficult, probably going to lose the ability to self-feed, and then even the respiratory muscles to be able to continue to breathe. So again, like we talked about before, this is where they would need to consider if how they feel ethically about life-prolonging interventions, like a feeding tube or a ventilator, okay? And then up at the top there, you see that I put ALS will not change their eye function, their bowel and bladder, or their sensory. And so that is pretty unique, and it's good to remember. So the client that I had that was in stage ALS, she still had complete eye function, and so she was able to use a communication device with her eyes, and that was really effective for her, and it allowed her to have some control that way. So that was really neat. Also, these clients maintain their bowel and bladder control, and so she needed to be dependently transferred to the commode, but she could tell when she had to go, and she could still control that. So, and then also sensory function. So they maintain the ability to feel. It's not like that they are dealing with a significant neuropathy throughout their body or something like that. So they still have the sensation. And so that's something to remember too, is that you can actually use that a little bit and educate the family that maybe they like lotion or a massage or having their back scratched and things like that. Okay, just for quality of life purposes. All right. Let's see here. So in those situations also with having that level of control, they could be able to use, the OT might be able to direct with an eye gaze communication device or something like that. They would also be able to feel, so they should be able to help direct skin checks or like we were saying, or be able to tell you when they have to go to the bowel and bladder. And so those are important ways to maintain independence as they're able, and that's if their cognition is intact to be able to communicate those things reliably. Okay. As far as the role of OT, I've put there that it will change as the patient declines. And so your textbook there, 35-2, has great interventions, and it's got it laid out for you. Please reference that. But some of the things that you would be thinking about here would be range of motion, stretching to prevent contractures. We're going to try to do anything that's going to we're going to try to prevent anything that may cause pain, okay? Because pain is doing the opposite of what we want to do with quality of life, right? So gentle strengthening, maybe splinting at one of the middle stages, perhaps. Maintaining independence however you can. Deep breathing exercises. Maybe it looks like refitting of a wheelchair if they're able to sit up, and how is that going to need to change with them as they change, okay? So then from the active range of motion to active assistive to then maybe they're able to do, their caregiver would be able to do passive range of motion. Then thinking about things like sensory stimulation. And so thinking about things like that, right? So just think about, these are all maintenance. Think about the downward trend. We're not going to be expecting a progress of sorts, okay? And so that's important for you to know, even if the family tries to push you to do more of those types of things, you need to know this, to have this knowledge in your mind. And then you also need to stay relevant, clinically relevant, because these things could very well change in the next few years as they continue to do research, right? All right, so again, ALS treatment is aimed at treating secondary complications. We're not going to be able to cure the cause of this condition. So some of the things that we were looking at treating would be the spasticity, prevention of aspiration, prevention of decubitus ulcer, prevention of contracture, and pain management. Okay. So again, the loss of function with ALS is more rapid, and it's not going to have the periods of remission or plateau as you see in MS. And then your textbook has this quote that I thought was pretty neat about kind of the grieving process. And it says, a person with ALS must cope with a fatal disease, whereas with Parkinson's or MS, they must cope with a chronically disabling condition. Okay, so just kind of think about that. Different terms of coping and different outlooks and future outlooks and outcomes. Okay. All right. Whoops. We'll stop here and